to everyone. Good afternoon. As we know that PCOS is one of the most commonly encountered disease now in our population. Out of every 5 females, they are having this, especially because of the lifestyle modification, and we are having the changing demographic profile. And but it is not. We need a lot of sensitization. We need to have, it's an urgent need of our clinicians. It's our responsibility to make our young females, all those particularly all those who are planning their obstetric career, or when they are having this kind of suffering from this problem, who comes to our clinic, 1 out of 5 maybe. So we have to make them understand the little bit of the pathophysiology, that this is not something which is really dreaded or something they should be really scared about, because it can be, the disease can be won over. It can be really we can see through it very easily, and we can counter the side effects or long-term negative health impact which it is having of the childlessness and all those things, or infertility and other health hazards on the long-term basis. This is one which we need to make them understand only simply by making their lifestyle changes, and because everything has changed, more and more of the sedentary habits, fast food, junk food, the kind of eating habits, that has to be monitored and has to be taken care of by the youth population. And so without much help in the future, they will be themselves tackle their own problem and be very confident about it. Obesity, which is like an epidemic, and sedentary lifestyles. In PCOS, we know by definition, all of us, that there can be menstrual irregularities, delayed menses, maybe it can up to 6 months or a year, or amenorrhea, infertility, and then the Rotterdam's, then we have a revised criteria of I would say acne, hirsutism, biochemical markers are also there. This is by definition, but what we are supposed to, the responsibility to us as a clinician, more importantly, is we have to induce and we have to motivate more and more. And I think for the lifestyle changes, and especially all those obese who have a high BMI and above 25, or overweight women, than those with a lean PCO, which can be, and with little help, they can always tide over and their own problems and this of menstrual irregularity, because making a weight cut down by only 10% will make them ovulate, and even on 10 to 15% on a regular basis. So 80% we are done when we are making our patients understand the phenomena, the pathophysiology of insulin resistance, of the dysregulated hypothalamic pituitary ovarian axis, which is not functioning, with more of hormones, male hormones surging high. And so we can, if we can give time to the counseling part, little more than the medication part, and then we can, with some help of medications, then we can of course make them really happy. And stressing upon the fact they need to exercise, eat the right food, right time, right place, and like this will turn the wheel of the entire cycle, of the vicious cycle of the PCO, which is something, it is counterproductive. When you are making more and more obese, in turn they are getting more of this PCO morphology on the ovaries. We are getting more and more follicles, and which are producing more estrogen, more obesity, again back more of insulin resistance. So the basic pathophysiology is the insulin resistance, which we really need to take care of, and half of the work is done only by the lifestyle changes. So rest of the times we need to, for if she is wanting fertility, induction, then we have to go in a step ladder pattern by medications, letrozole. Then we need to monitor the follicles. Then if she is not behaving well with that and not responding, then we need to go for a HMG injections. And then even if she is not, then we can go for laparoscopic ovarian drilling. That can be a fourth strategy to impact upon. But necessarily we need to counsel our patients in a very good way, giving some time to the patient on this particular entity, which really needs to be understood by the patient herself, that how to go about and not get panicky about their menstrual irregularities and all these obesity. And because what we need to impact upon is their lifestyle changes, but which has to be consistent, constant, and initiate to make effort on our own, because it's not it's a combined effort of the doctor and the patient herself. It's not an overnight magic which can be done with the patient, and this has to be understood by the patient.